now. We'll get started in about 3 minutes, just to make sure everyone has a chance to join. Let me know if you cannot download the slides. That would be a bad time. Alrighty. I'll send out cardiovascular now, and when we switch over to pulmonary, I will send out pulmonary.
The PDF, right-click on the PDF and select
Alrighty, we can go ahead and get started. Can you hear me?
You can then select your choice.
See my
For example,
screen? Send out. Awesome. Cool. Thank you, guys. Today we have heart and lung physiology, cardiovascular and pulmonary. We'll do cardiovascular first, and I've sent out those slides, and then once I finish that, we'll transition over into respiratory physiology, and I'll send out the slides for that at that time. Alrighty. If you can't download the slides, just let me know. You can shoot me an email afterwards. I can send them to you via that as well. But yeah, hopefully you guys are having an awesome start to your weekend. Let's get going. So as with every lecture, we start off with a couple slides of what we need to know. So for today, what we need to know for cardiovascular system, so we know its functions, what it does, circulates oxygen, nutrients, hormones, all that good stuff, and also waste so that we can get rid of that waste. We're gonna look at its role in thermoregulation, we're gonna look at the structure, the gross anatomy of the heart, its 4 chambers. We're gonna look at the blood vessels, so the endothelial cells, their smooth muscle that surround them. We're going to look at the pulmonic and systemic circulatory systems, and then their pressures as well. So the systolic and diastolic pressures, and we'll kind of talk about how we take that and what it really tells us. And then we're going to look at capillary beds, what that does, how it kind of causes an exchange of gases, how it releases the oxygen and takes up carbon dioxide for you just to then breathe out, which we'll talk about more in the next lecture as well. And the composition of the blood. So it's not just red blood cells and water. There is a plethora of stuff. We're also going to get more, a little bit more into the nitty-gritty of oxygen transport via hemoglobin, and specifically the oxygen affinity for the hemoglobin itself. Let's see, we have 36, so someone might not have gotten the slides. Alrighty, so one more time. Cool. Let us talk about the anatomy and the structure first. So this is our heart. Our heart is 4 chambers, and it is separated between right and left heart. And so we'll talk more about fetal circulation in the reproduction and development lecture. But today we're talking about adult circulation. So in adult circulation, the right and the left heart are very, very separated, and the right heart holds oxygen poor blood, and the left holds oxygen-rich blood. And where does it get oxygenated? It gets oxygenated in the lungs. We'll talk briefly about pulmonic circulation here in a couple slides, but we will talk about it in the second half of this lecture. So the big parts, in the right heart, we have the right atrium and the right ventricle. So the atrium is the upper chamber. So we have 4 chambers, right atrium. The right atrium, it travels then to the right ventricle. And this is oxygen poor blood. This is blood that has come back from the systemic circulation, back from the body, and has already been used up all its oxygen stores. So it's coming back to the blood. It's coming back to the heart, coming back to the center of its circulation. Because then once it gets past the right ventricle, it'll be sent to the lungs, and it'll be sent to be oxygenated. So once it comes back from the lungs, it'll enter the left atrium, left ventricle, and then out to the rest of the body so they can deliver oxygen to the rest of your tissues. When you go through each of these chambers, you will be passing by a valve. And so you do need to remember which valves are what and the order at which they come. So the mnemonic I use for heart valves is toilet paper, my ass, TPMA. The first, you go through the tricuspid valve between the right atrium and the right ventricle. And then once you leave the right ventricle and go out to the lungs, you have to travel through the pulmonic valve. And then once you're back into that left atrium, you travel to the left ventricle, you need to pass through the mitral valve and then out to the aortic valve. So don't ever forget this, toilet paper, my ass. For some reason, this is the only mnemonic that ever really stuck for me with this. So catch you screaming TP my ass on the real MCAP. Yes, please do. Please do. No, it'll throw everyone else off, but it's really just helping you in the end. Alrighty. So yeah, tricuspid valve, then pulmonic valve, then mitral, and aortic. And so what these valves do is it keeps blood moving in one direction. So we need directionality. We can't have backflow. Backflow would cause clogging, and that is not good. So when we have contractions of the heart, it's going to travel to only where it can. So it'll travel through said valve, and then as the ventricles contract, and it shoots it back up. If this valve is going to keep it from moving backwards into the right atrium, and it'll keep it moving in one direction back to the, out to the lungs. So the valves, toilet paper, my ass. You'll never forget that one now, I promise. Okay. So we do have 2 different types of circulation. You have systemic circulation and pulmonic circulation. So pulmonic circulation is between the heart and the lungs. Systemic circulation is between the heart and everything else. And so you need to know basically the path of which blood travels. And so any time blood is leaving the heart, the type of vessel it'll be traveling through is an arterial type vessel. So you go through arterial blood flow. So a lot of people like to separate arterial versus venous blood flow based on oxygenated versus deoxygenated. And that's not correct because it's kind of reverse between systemic circulation and pulmonic circulation. And what I mean by that is in the arterial system for systemic circulation, you go from the heart out to the aortic arch, down through the arteries. So let's go through the arteries, you go arterioles, capillaries, venules, veins, vena cava, and then back to the heart. And so when you're leaving the heart here, you're in oxygen rich, you're traveling through the arterial system. When you're going back through the venous system, it's oxygen poor. That's for systemic circulation. It's quite the opposite for pulmonic. When if you're traveling from the right ventricle out to the lungs, you get that contraction. You have pulmonic valve, and we have blood leaving the heart that is oxygen poor. Now, it's oxygen poor, but it's still leaving through a pulmonary artery. And so, as you see here, our artery has oxygen poor blood when it's in the pulmonic circulation, but when we're in the systemic circulation, the arteries have oxygen rich. So do not label arterial versus venous based on the oxygenation status. It's all based on directionality. So if we're leaving the heart, it'll be an artery. If we're coming back towards the heart, it'll be venous flow. And so as we see, we're traveling back to the heart. Here we have some pulmonic veins, and the pulmonic veins here are oxygen rich because they're coming back from the lungs, which just oxygenated it. There's a question. Yeah, so a lot of people like to say that arteries carry oxygen-rich blood and veins carry oxygen-poor blood, and that's how they use it to differentiate artery versus vein. But that is not accurate because it switches in pulmonic circulation. Pulmonic circulation, arteries carry oxygen-poor blood, and the veins carry oxygen-rich blood. So arterial flow is anything that is leaving the heart. Yeah, artery away. Arterial flow is anything leaving the heart, and venous flow is anything coming back to the heart. So you might get a question where it says, hey, we have blood that's starting in the right atrium. It's what is the path that it takes? And so it'll give a list of different types of vessels, different locations, and you have to be able to recognize what path it takes. So what the path it takes? There's a question quick. Yeah. So we're going to go through the path right now. Okay, let's start with right atrium. The right atrium contracts, it's going to send us through the tricuspid valve. So we're in the right ventricle. And so from the right ventricle, we're not going to travel to the lungs. And so maybe in previous classes, it was fine just to say, hey, right ventricle to lungs, lungs back to heart, and then so on and so forth. But you need to take it a little bit, take a little bit further. And so we need to add in some vessels. So we have the right atrium, we go to the right ventricle contracts, we go through the pulmonic valve, and now we are in pulmonic circulation. And so we leave the heart through the pulmonary artery, right? Because arteries leave the heart. And so as we're entering the pulmonary artery, we're going to go into the pulmonary capillary bed where we'll have some gas exchange. We'll talk about more gas exchange in the next lecture, but what we're going to do is we're going to be picking up oxygen and we're going to be blowing off carbon dioxide. So we're going to do some little gas exchange. We're going to oxygenate that blood. That blood will come from the pulmonary capillary bed back to the pulmonary veins. So we need these veins go back to the heart. So we have these pulmonary veins that drain into the left atrium. The left atrium, we go into the left ventricle. Left ventricle contracts, and now we're contracting really hard to get it out to the rest of the body. Now we're entering systemic circulation. So in systemic circulation, we leave the left ventricle, we go out the aorta or the aortic arch, and we travel into the arterial system. So we have aortas that break into smaller vessels called arteries, which break into smaller vessels called arterioles, even smaller vessels called capillaries. So this is where we're going to have the exchange of gases again, where we're going to deliver that oxygen to the tissues. We're going to pick up all that wastes, and we're going to put that back into the venous blood flow. And so we're going to start out with very small venous vessels called venules. They're going to combine and create bigger vessels called veins, which are going to combine to create an even bigger vessel called the vena cava. So we have inferior and superior vena cava based on directionality. So if it's above the heart, it's a superior vena cava. And if it's below the heart, it's inferior. and then that vena cava drains back into the right atrium. And then that's where we're back when we're started. So you need to be able to follow the path at which that blood takes. They may give you a correct order, but leave out steps. And so you need to be able to keep straight in your head, what the order is, what comes before what. They may say, the correct answer might be from the right atrium. The correct answer might be left ventricle, descending aorta, arteriole, vein, vena cava. And so I just left out a bunch of steps, but technically it's the right order. So that's something you need to keep in mind. I have seen quite a few questions like that, where just you need to know the order, but they'll leave out a ton of steps. Any questions on the path that blood takes? Let's see. And do you recommend that we know the blood flow in the amount of detail you just described? Yeah, that's actually not a ton of detail. It's way more in depth, a lot of different types of veins, a lot of different types of arteries, arterioles. That is very macroscopic, and you need to know into the detail, which is pretty much on the slide. Whatever's on the slide is to the detail you would need to know. So that's why I have these to design the way they are. These are for you study guides. All right, any other questions? All right. Let's go into the structure between these two types of vessels. So the structure between arteries and veins are quite a bit different. So on the left here, we have an artery, and on the right, we do have a vein. And so one thing that we noticed right off the bat, or that I noticed right off the bat on the left, is the wall of the artery is much thicker. It is a very thick wall. And where we see the thickness coming from this middle layer called the tunica media. So the tunica media, which I have listed out what's in each layer on the next slide, is a lot of smooth muscle. And so there's a lot of different types of control we could do with the arterial system. We can dilate it, we can contract. So whether these muscles relaxed or whether it's contracting, we could change the overall radius of the vessel itself, but also the thickness keeps the arteries a bit more sturdy. So why would we want arterial system to be more sturdy than the venous system? You just type it in the chat if you have an idea. Why would we want the arterial system? Why would we want those tubes, those pipes to be thicker, more robust? Yeah, so it has to be okay with the pressure. So we have a lot of pressure in the arterial system. The reason why is because it's being, that heart is pumping, the heart's contracting, and it's just shoving blood into the arterial system. So as the heart contracts and we're pumping more and more blood, it has to be able to handle the pressure that exists in the arterial system. And so we don't want it to stretch and tear. That would cause an aneurysm. So as you get older and you have some calcifications, maybe these become more rigid. And when they become more rigid, they can't deal with that pressure and you start to get small little aneurysms, which is very bad. And that's a lot of problems with people with coronary artery disease. It can block, it can also decrease the elasticity of these vessels, damage them to the point where they just break and you start to cause internal bleeding. Something that's unique about the veins is we have a valve here. So why in the heck would we need valves in a vessel? And that's because the pressure system in the vein is just so low that if we're considering gravity, and let's say this vein is traveling up the leg, right? We don't want backflow. Exactly, Sophie. We don't want backflow. We need to keep it going in one direction. Otherwise, you just have all the blood in our lower extremities just be pooling in our feet. That would not be good. And so we have valves in the venous system because we don't have a pressure helping it work against gravity. And so we have what keeps it going is, we have fluid behind it, pushing it forward to some extent. Our muscles contract and can help aid blood moving in one direction. But as it gets past this valve, just to prevent anything from going backwards, it kind of sits back and pools in these valves. Something that is unique in veins is they have valves. Arteries do not. Let's see. So the pressure difference is caused by the heart pumping, not the oxygen in the blood. Yeah, so the pressure is not caused by oxygen in the blood at all. We will talk more about a little bit of fluid dynamics here in a couple, in a few slides. So this is, when you have that fluid dynamics lecture, this is the most applicable time you can use it. Yeah, so arteries don't need valves because the pumping heart keeps blood moving in the right direction. So the blood pressure is not due to oxygen concentration at all. It's pretty much just fluid dynamics. What's the diameter of the vessel? What's the speed of the blood flow? And the stuff like that. All right, so in those different, and also in the capillaries. Capillaries are these very, very small, very thin vessels where a lot of diffusion can occur. So we can exchange nutrients from the tissues and the blood supply. And then your question, just make sure smooth muscles in both the arteries and the veins allow for vasoconstriction and vasodilation, right? Yes, but as you can see, there is a lot more muscle in the arterial system, and so you can cause a lot more vasodilation and a lot more vasoconstriction. So these guys, the constriction is what really keeps blood moving in one direction or another. Alrighty. So the different layers. So we have the endothelium. It's the very most inner layer. It does release substances to control vascular relaxation and contraction. So it releases substances to the smooth muscle, essentially, which can cause it to contract or relax. And so when you take things like sildenafil, which is also known as Viagra, people take it for pulmonary hypertension, not just erectile dysfunction. It's more commonly used for pulmonary hypertension, when basically the pulmonary arteries are way, way too high pressure where they can burst. You give them sildenafil, which is a vasodilator. What it does is it goes in and it kind of blocks the substances that control contraction, and as an agonist, promotes things that cause vascular relaxation. It causes the pulmonary artery to dilate and relieve some pressure. But the guy that really plays the biggest role in vasoconstriction and vasodilation is the tunica media, right? It's where all that smooth muscle is. If we didn't have any of that smooth muscle, we would not have contraction or constriction and dilation that is needed. So if we had just endothelium that released vascular relaxation or contraction factors, if it didn't have a tunica media, we wouldn't actually get any of that vasoconstriction. And the tunica externa, you don't really need to know a lot of these in detail. This is just to give you a little bit more background. It is very collagenous. So this is where it gets its structure. So we have another structure called the vasa vasorum, which provides, there's some little blood vessels that provide nutrients to the blood vessels themselves. So even blood vessels need a blood supply. So we have a structure called the vasa vasorum. But the tunica externa is really collagenous. And what collagenous means is a lot of protein to give it a lot of structure. And so the structure of the vessels is really just kind of backed up by the tunica externa. Alrighty, any other questions? No, we don't. Okay, so let's talk about that. Blood flow and pressure. What dictates the pressure? What dictates blood flow? And that is fluid dynamics. There's another question. Is the tunica intima, media, and externa all smooth muscles? No. So these are just different layers of the blood vessel. The tunica media is where you got that smooth muscle and some structure. So it's that middle layer. So if you go back, the tunica intima is this very inner endothelial layer. We have the tunica media, which is a lot of the smooth muscle, and the tunica externa, which you see the vasovassorum, and you see some collagenous structures in there as well. Alrighty. So make sure everybody has these slides because people are late. Cool. Okay, I'm sending the slides again one more time. Okay, so let's talk about the blood flow and blood pressure. The three main really fluid dynamics equations, fluid dynamic type properties that play a role in blood pressure are listed here. So fluid velocity or blood flow speed is determined by the law of continuity. What pressure the fluid places on its vessels is dictated by Bernoulli's principle, and then resistance of the vessels that they apply on the blood flow is Poussey's law. So have you guys done the fluid dynamics lecture yet? Just a question. I haven't looked. Not yet. Okay. Yeah. So these are the law of continuity itself is very straightforward, and I'm definitely not a physics person. So even on the physics section, the way I thought about Bernoulli's principle, which you'll go into in more depth later, and the way I thought of Poussey's law are actually shown here. These are both extremely simplified, but I found that it helps with blood flow and it helps with just physics in general. So let's go through each of these. What determines fluid velocity is the law of continuity. So this is A1, I'm going to draw A1 times V1. So the cross section of tube, these are all tubes, right? We're in tubes within a tube. It is the blood vessels. So we're talking about different size tubes here. So cross section of tube 1 and the velocity of the fluid in tube 1 versus the cross section of tube 2 times the velocity. So that is the equation. It's the law of continuity. So let's say we have a small tube that goes into bigger tube. How does that change? How does the difference in the cross-sectional area actually change the flow of that blood? Yeah, so this is one where you can think of a garden hose. We'll get into this in a second. So let's say we have a cross-sectional area in tube 1 of 1 centimeter squared, right? So just 1. And the velocity in tube 1 is, let's just say, 2 centimeters per second. Let's make the math easy. Equals, so let's say the cross-sectional area of the second tube is twice as big as the first tube. So this is definitely not to scale. But let's say we increase this cross-sectional area, we double it. What will that do to the velocity, the second velocity? It decreases it by half, exactly. So then the velocity drops to 2. So by increasing the cross-sectional area of that tube, we have just decreased the speed of the fluid. And so this is when you use a garden hose, right? And when you put your thumb over the top, you're decreasing the cross-sectional area of the output area, of the exiting area of the garden hose, and the water speeds up. So that water speeds up because you've decreased the opening to the hose, and that is the law of continuity. And so I'm using 2 to 1. That's just easy math. You can use anything. We can have, it's essentially to find the velocity of the second one, just rearrange it, A1 times V1 over the cross-sectional area of the second tube. That is just the rearranged equation to get the second velocity. And that is all the law of continuity is. And so you'll go into this more in the fluid dynamics lecture. But that is one thing that dictates fluid velocity in a pipe. In this case, the pipe is the blood vessel. Let's see. There's a question. You always confuse this concept with conduction, where if you have a larger area, it's easier for ions to flow. What's the difference? What do you mean? So, I think I'm not too good on electrochemistry, but I think it's the same thing, right? If you have a wi bigger wire, you can increase the speed. I think that that's a resistance thing, so we'll get into that. I think that's a Poussin's law thing. Just don't worry. Alrighty. Yeah, so that's just kind of that's a fluid pressure thing. Okay, I guess yeah. Um, Electrons and ions work differently. It's specific electrons. In a wire, it's not wouldn't be ions. Um, but I'm not an electrochemistry guy. That is not my forte. I cannot answer that question off the top of my head. Alrighty, let's keep moving. So Bernoulli's principle basically says a faster fluid will exert a lower perpendicular pressure. And so this one kind of confuses people. Let's say we have a fluid traveling from left to right. The faster it is going, and from the left to right direction, the lower the pressure it'll put in the perpendicular direction. So if we have a fluid or blood in a vessel, if it is moving faster in this direction, it'll exert a lower pressure on its vessels. But that is assuming everything is completely straight. Yeah, if we had something right here, the faster it goes, the harder pressure it puts on this type of surface, but the lower the pressure it puts on the perpendicular surface. So we use Bernoulli's principle in planes. So in planes, what we do is when we have a wing right here, we speed up, actually we slow air going underneath, and then we speed up the aerodynamics of the wing. We speed the fluids going above. So there's different types of fluids. Fluids can be gases or they can be liquids. Those are both fluids. So in a plane, so this is a plane wing. That I'm not an artist by any means. By speeding up the air above the wing, you are exerting a lower pressure down on the wing. So exerting a lower pressure down on the wing would allow the net force to push the plane up. Wait, that's hype. Okay, yeah, so that we take, advantage of Bernoulli's principle with planes. By speeding up the air above the wings, we are decreasing the pressure pushing down. So then the first time I saw Bernoulli's principle in action, I was like 6 years old or something like that. I was having dinner with my father. Go back. This blew my mind at that age. He had a cup of water. In the cup of water, he had a straw. This is a 100% true story. And so what happened is he blew across the straw, uh, blew across the opening. And what that did is that decreased the amount of pressure pushing down into the straw. So what happened was that the water naturally pushed its way up because the pressure going down into the straw was thus less. And so that was the first time I saw Bernoulli's principle. So when I think of this type of principle, I refer back to planes. I refer back to this straw story just to kind of remember that if we have a fluid, darn it, what did I just do? There we go. If we have a fluid moving faster in this direction, it's going to be pushing a less pressure in the perpendicular directions in both ways. Yeah, try to do it afterwards. Do it. And then the last is resistance. And so I think the resistance in your question in increasing different types of radiuses on different types of wires, where that comes in is resistance. So we have this guy right here. This big R is resistance. This is the radius of our tube. the length of the tube and the viscosity of our fluid. And so in this case, in the blood supply, the fluid is a liquid. It's our blood. So pretty much if we look at the exponents here, this is already a very, very simplified version of Poussey's law. And this is for even for physics, this is what I use. I really don't go down into the big long formulas. I really, really love guesstimating. If we look here, and we have different exponents, and then we have 1, 1, 1, and then we have an exponent up to the fourth. So really, the biggest guy that plays a role in the resistance is the radius of the tube. And so I even sometimes simplify Poussey's law into something as simple as this. And what this is saying is that the radius is inversely related to the resistance by a factor of 4. That is effing massive. So if we actually think about this, let's say we have a radius of 2, right? So this radius of 2, the resistance to go to the fourth, right? Whatever that is. So 2 times 2, 4 times 2 is 8, 16. So if we have a radius of 2 centimeters, the resistance will just be 1 over 16, right? Let's say we double the radius, and the radius is now 4. So if we double the radius and the radius is now 4, gosh, math. So 4 times 4 is 16, times 4 is 64, times 4. What's 64 times 4? 256. Okay, cool. 256. So, oops, no, is 1 over 256. So just by taking oops, that's 264, 256. So just by doubling the radius, going from 2 centimeters to 4 centimeters, we went from a resistance of 1 over 16 to 1 over 256. That tiny little increase of just 2 centimeters in the radius of the tube decreased the resistance by a ton. And it goes in it goes in the opposite direction too. If we had a tube with a radius of 4 centimeters and we decreased it to a radius of 2 centimeters, just let's say by vasoconstriction, we just took a tiny resistance of 1 over 256 to a relatively massive resistance of 1 over 16 compared to this one. And so resistance is largely dictated by the radius of our tubing. And so that is something to keep in mind, what vasoconstriction does, what vasodilation does, how that affects resistance. When we go from a artery to an arterial, how does that roll? So all these things will be added together and have to be taken into account just more at a conceptual level to think of how the pressures differ from vessel to vessel. So really calculating what's the absolute resistance of a vessel. You might see, let's say, given, if we have a vessel with a radius of 32 millimeters, and we decrease the radius via the vasoconstriction to 16 millimeters, to what factor does that adjust the resistance? So you have to think it halved it, so to what factor would it increase it? And so it's more of a conceptual type thing. Calculating absolute numbers is something you'll have to do for this, but let's kind of apply this to each of the vessels. Alrighty. So if we look at flow velocity here on the top, in the systemic arteries, you have a very fast velocity. But in the capillaries, we have a very slow velocity. Well, that doesn't make sense, right? If we have a massive artery and compare it to a small little capillary, law of continuity would say as we go to a smaller cross-sectional area, wouldn't the speed of the fluid increase? And so that's something that is a little bit probably counterintuitive. If we're going from this massive artery to this tiny capillary, why is the velocity also decreasing? Because the reason why is if we look at the cross-sectional area, capillaries are a lot higher than arteries. Like, hey, wait, what does that mean? And it's because the overall combined cross-sectional area of all the capillaries are just that much greater than the arteries. If we have one artery, we're going to branch into a bunch of arterioles. All those arterioles are going to branch into a bunch of capillaries. We have so many capillaries that the combined cross-sectional area is much, much higher than that of the arteries. So because we have a higher cross-sectional area, the speed of the fluid is going to slow down. So the flow velocity will decrease. Yeah, so that's something that's a little bit just to keep in mind. That is one of those gotcha type things, gotcha type pieces of information that I've seen quite frequently. The cross-sectional area of an artery is much less than that of the capillaries, just because there's so many of them. If we go from the blood flow from one artery doesn't travel into one arteriole to one capillary. It's going to branch and branch and branch. And so you can't possibly compare, one artery to one capillary. It doesn't work like that. The blood is going to branch. It will bifurcate and will split up. But then we are going to have all these numerous capillaries. They're going to start recombining into the venous system. So they're going to start combining back into bigger veins. So as we go into a smaller cross-sectional area, it'll speed up just a bit. And then we get into the lung capillaries. Same thing for the lung capillaries, right? This is going to slow way down. And the reason why is because we have so many capillaries in the lungs, it'll pretty much have the same effect. And so when we think of the law of continuity, we need to keep this in mind. The overall sum of the cross-sectional area of the capillaries, both systemically and pulmonic, are greater than that of the arteries. Alrighty. There's a question. Does that mean that there is more resistance in the capillaries? There is a lot more resistance in the capillaries when you compare one capillary, even, all the capillaries to arteries. It's just the radius of these vessels are just so much smaller than the arteries as well. There's going to be a lot of resistance. And so you're also going to have bifurcations or splits in the vessels. So the branching adds more resistance because you'll accidentally hit the spot where it branches. So there's a lot more resistance in the capillaries than there is in the arteries. And if you kind of think about it as well, when you get some, plaques and calcium built up in the arteries themselves, and you're really even the smallest changes in the radius, if you're having this plaque buildup, even the smallest changes in radius of your arteries is having massive, massive ramifications in terms of resistance. And that resistance can potentially put too much strain on your blood vessels and cause them to break and rip as well. Alrighty, so the actual pressures. So when we can measure pressures. So if you've ever taken a blood pressure yourself, very cool. If not, you've likely had a blood pressure taken on you, assuming you've ever been to a doctor. So this, if you've taken it, you know this, but there are two numbers when we look at blood pressures. There's the systolic pressure and the diastolic pressure. And those both tell us different things. The systolic pressure is the pressure created by the ventricular pressure. So the ventricles of your heart contracting and put all this pressure, all the strain on your blood vessels. That is a systolic pressure. The diastolic pressure is just when you're at rest, the heart's not contracting. It's basically in between contractions of the heart. What is just the normal elasticity of your blood vessels? What is the peripheral resistance? What is the overall just in between heart rates? What is the pressure in those vessels themselves? So this is the systolic and diastolic. So how do we actually measure this? We use a blood pressure cuff. And so what we do in a blood pressure cuff is we pump it up. I'm sure you've had that done. So if I draw, we have an artery. We usually take a blood pressure on the brachial artery up in your upper arm. What we're going to do is we're going to expand this blood pressure cuff, put more and more pressure. What we're going to do is we're going to put pressure on this artery and press it against this bone being your humerus. And so we're going to do more and more pressure, more pressure, more pressure, and to the point where we have completely flattened this artery. Once we've flattened the artery, we can start to decrease the pressure in the cuff, in the BP cuff. So we're going to slowly decrease it, slowly decrease it. Eventually, the pressure generated by your heart can slowly press up on the vessel, and it can open it up slightly. So we have the pressure from the cuff pushing down, and then the pressure inside the vessel generated by the heart pushing back up. And once we keep decreasing and decreasing the pressure in the blood in the cuff, we'll eventually reach that blood pressure where the heart can open up that vessel. And when we open up that vessel, we'll get a little bit of blood flow through the vessel. And that blood flow is very turbulent. And so when you're listening on a stethoscope, you're going to hear a sound. And that first sound is when you're getting this turbulent flow through the blood vessel because it was just opened up. That's called a carot cough sound. And what's going to happen is the heart's going to relax and the blood pressure cuff will naturally flatten it back out again. And you don't hear anything. And then we're going to continue to decrease and decrease and decrease the blood pressure cuff. The heart will contract and it'll open it up again. And you'll hear blood flow again. You'll hear the carot cough sound. You'll hear the turbulent flow. And so that very first sound we hear is the systolic pressure. It's what the pressure is inside your vessels. And we know that because it was able to push up and open up against the BP cuff. Eventually, you'll stop hearing sounds. And that's because the natural elasticity, the natural pressure that exists inside the blood vessel cannot be beat by the blood pressure cuff. So it's going to stay open. And you're no longer getting that opening and closing of that vessel. You're no longer getting that turbulent flow. You'll stop hearing sounds. And when you stop hearing sounds, that's the diastolic pressure. So we can tell with the pressures in the vessels based on when we hear that first sound, when it can finally beat that BP cuff, and when we stop hearing sounds, when the BP cuff can no longer beat the pressure inside the vessel. And we use these to get a sense of perfusion to the vital organs. So we take these and we create this mean arterial pressure, or also called the MAP value. This is how we actually calculate MAP. You won't need to calculate it. It's just diastolic plus 1/3 times the difference between systolic and diastolic. You don't need to actually calculate that, but you need to kind of determine, hey, what would the MAP tell us? So the normal range for a MAP is about 70 to 100 millimeters of mercury. So if we're in this range, the perfusion or the blood flow is good. We're happy. We're a-okay. If our MAP is below 70, we're having what's called hypoperfusion. This is telling us that we're not getting adequate blood supply to our vital organs. We can have organ failure. Maybe we're not getting enough blood to the brain. Maybe we're not getting enough blood to your muscles, whatever. We're not getting enough blood perfusion, blood flow to our vital organs. That's not good. We don't want that. If we have a mean arterial pressure or MAP we're above 100, then the pressure throughout the body is way too high. But then we're at risk here for aneurysm. We're at risk for stroke. And so people, when you have, I've seen patients where their systolic pressure is 210 and their diastolic is 110. And so right off the bat, I don't even have to do the math. You can tell that, the mean arterial pressure, the mean is going to be somewhere between those numbers. It's above 100. They're at higher risk for stroke. And so you ask them, hey, you got a headache? Do you have any ringing in your ears? Are you having any vision problems? because they're at high risk for stroke. And so that is something not good. We want to keep it in between 70, 100. There is a happy medium. We don't want too low because we're not getting enough vital perfusion. And we don't want it too high because we don't want to rupture our blood vessels. You had a patient the other day like that, but she had dementia, so couldn't answer questions. So we had to rush her to the ER. Yep. Dementia causes so many problems like that. And yeah, it blood pressure tells us a lot of things. And so if you have a chronically high blood pressure, you're putting essentially so much stress on your blood vessels that you can be at higher risk for developing an aneurysm, having stroke, not good. And so you can also have acute changes. I had a friend whose mother was short of breath and was super, super hypertensive. And so kind of a mix of having low oxygen saturations, which we'll talk about oxygen hemoglobin later on in this lecture. Between having low oxygen saturations, being short in her breath, and very hypertensive, I was like, you need to go to the ER. Turns out she was having a pulmonary embolism. There was a blockage in the blood flow in the lungs. And so the hypertension and the blood pressure can tell you a lot of things, a lot of diagnostic indications. So that is not something you want to ignore when you are a clinician or seeing patients. There's a question. So to recap, the graph tells us to distinguish systolic and diastolic pressure. So the graph itself is the aortic pressure is essentially what we're measuring using the blood pressure. We're using the arteries though. It is essentially just saying, hey, normal systolic pressure is created by ventricular ejection, so contraction of the heart, shoving it into the aortic system, shoving it into the arterial blood flow. And then the baseline pressure, our minimum pressure before we have the next contraction, is the diastolic. And so we're constantly functioning normal range between 120 and 80. Even that is now considered high blood pressure. The American Heart Association changed the guidelines. You now want a systolic blood pressure below 110. So that you don't cause any cardiovascular issues by straining out your vessels later on in life. And so even 120 it's normal, but considered slightly hypertensive nowadays. Big Pharma does want everyone to be on hypertension meds. Yeah. So wait, new normal is 110 over 70. I mean, yeah, 120 over 80 is essentially normal, and for most people, that's fantastic. But I think it was like 12 months ago, AHA came out and it's like, hey, new recommendations for heart health is systolic of 110 and diastolic of 70 is good. So yeah. Yeah, so that is quite the low blood pressure. So good luck reaching that one. Some people naturally have a systolic of, in the 90s, which is quite insane, which they have like 90 over 60, which is low. For them, it could be baseline. If you have too low of blood pressure, it can lead to hypotension. A lot of people can get orthostatic hypertension where, hey, they stand up and the blood pressure can't really deliver enough blood to the brain. You get a little bit dizzy. So if you ever stand up and you feel a little bit dizzy, that is orthostatic hypotension. The blood pressure in your veins and your vessels cannot keep up, and you can't deliver enough oxygen to the brain quick enough. Don't athletes have a low blood pressure too? Yeah, they do have a low blood pressure. It's more of they have a healthy blood pressure more so because their heart health is fantastic. Their muscles are conditioned. They don't need their cardiac output. It is lower essentially to at any given moment. If you're out of shape, your heart rate is going to increase because your heart can't contract hard enough. So it's trying to like basically compensate to make sure all your organs get enough oxygen. But if you're conditioned and you're an athlete, your heart can contract hard enough and where it can slow down because it still meets up with the demand because it's so strong. Alrighty. Let us keep moving forward. So it's the composition of blood. So it's not just water, and it's not just red blood cells, right? So it is about 55% plasma, 4% white blood cells and platelets. So your immune cells, white blood cells are immune cells. We'll talk about more of those in those immune lectures. 41% of it is red blood cells. So what is in plasma? So plasma has water, has a lot of amino acids, a lot of different nutrients, glucose, right? Electrolytes. It has waste, so urea, breakdown of muscle, right? So gases, waste can be gases as well. Carbon dioxide is a waste. And so we have a lot of different things dissolved in the plasma. So it's not just water. And so there's a bunch of stuff in your blood. So keep that in mind. You need to know that all these are in plasma. A lot of times people just think blood is plasma, which people just think is synonymous with water, white blood cells, and red blood cells. And so blood is made up of all of this stuff. For red blood cell production, it starts. The red blood cell production is called erythropoiesis. That's just a Zing term that you would need to know. Erythropoiesis, the production differentiation of red blood cells from pluripotent hematopoietic stem cells. So you don't need to know the differentiation steps. You don't need to go that a pluripotent hematopoietic stem cell differentiates into a proerythroblast, into an erythroblast, into eventually erythrocyte. What I need to know from this slide is that red blood cell production is called erythropoiesis, that hemoglobin synthesis, the protein that carries oxygen in your red blood cells, that starts in the bone marrow. And by the time these cells leave the bone marrow and enter the blood, they already do have their hemoglobin and are ready to function. Does continual blood donation contribute to lower blood pressure? No, it does not. You can have essentially an acute lowering of blood pressure if you donate too much, but your body will start producing more blood. You'll start retaining more water to kind of counteract that. So giving blood donation won't affect your blood pressure overall, but you may have an acutely low blood pressure from donating too much, where you feel a little bit dizzy, a little bit woozy. All right. How do we regulate the plasma volume? So let's say, hey, we did give out too much blood, or we maybe have too high of a blood pressure and we need to regulate plasma volume. Essentially, why would we need to do that? Because plasma volume will dictate blood pressure. If we have a higher volume inside these blood vessels, we'll have a higher pressure because there's just an overall greater volume that sits there and pushes up on the vessels, adds more pressure. And so if we decrease the volume, there'll be less fluid to play a role in the blood pressure itself. And so we can actually, our body can try to regulate blood pressure by adjusting plasma volume. So how do we do that? We could do capillary fluid shift, where at the capillary level, we can just get rid of all this plasma and send it into the interstitial spaces. So the spaces between tissues and whatnot, we can kick out some water and send it there. You can also have, at the kidney level, we'll talk about that more at the adrenal GI and kidney lecture, you can essentially increase capillary fluid shift at the glomerulus and increase glomerular filtration rate. That's what GFR stands for. We'll talk more about that. And during the kidney lecture, you can have osmoreceptors. So osmoreceptors will say, if our blood is too dilute or too concentrated, we can alter urine output. So we can either create more concentrated urine, create less concentrated urine. Volume receptors can also say, hey, let's create more concentrated urine. Let's create less concentrated urine. Baroreceptors which measure pressure directly. Also, they could change vasodilation, but can also change urine output. And the renin-angiotensin system, which we'll talk again in the adrenal GI and kidney lecture, can alter urine output through sodium reabsorption or not. And so, as you can see, regulation of plasma volume is highly related to the kidneys, highly related to urine output. So we'll talk more about regulating the plasma volume in that lecture. I don't think that was covered in the reading, but that is something that will be covered, I believe, in the kidney reading itself. This is just kind of, once you do kind of look at the kidney lecture and whatnot, you can come back and think of like, oh, how does that change plasma volume? So it's a little bit hook that you can bring it back into. Blood generation, I don't think it's covered in the reading, but for the blood generation, just know it's called erythropoiesis, and that hemoglobin synthesis starts in the bone marrow. I've encountered that specific tidbit in a few standalone questions. And what is GFR? GFR is glomerular filtration rate, which we'll talk about in the kidney lecture. That is glomerulus and is in the kidneys itself. So this is a slide when we go over the adrenal GI and kidney lecture, come back and think, how would the kidneys really affect blood pressure through plasma volume? So this is just kind of hook to tie it back into that lecture. What was it that I encountered in the standalone questions? Where production of hemoglobin starts, where hemoglobin synthesis starts, and that is in the bone marrow. Alrighty, hematocrit is a diagnostic test that we could do in a CBC. So by drawing blood, we can get a measure called a hematocrit. So what is a hematocrit? It tells us the percentage of red blood cells in a given volume of blood. So if we take a given volume of blood, find the percentage of that is the red blood cells, and you get hematocrit. What a low hematocrit can tell us, well, it's called anemia, which you might have heard, is when you have a low count of red blood cells. A low hematocrit can mean, hey, maybe you have some internal bleeding somewhere. Very often, you can find people with hidden GI bleeds, where somewhere up in their duodenum, there's a bleed going on. They're becoming anemic, they're becoming very tired, very weak. A low hematocrit can tell you, hey, maybe there's a hidden bleed going on. You can have red blood cell destruction that could be autoimmune, or you can just have a lack of nutrients. Let's say maybe you're not consuming enough iron for that hemoglobin. So a lot of different things can cause a low hematocrit. It's called anemia, right? So what that can manifest as is lethargy, weakness. If it's a very, very severe, you can have shortness of breath. That's just because you don't have the red blood cells to hold on to the oxygen and to deliver oxygen to the body. If you have a high hematocrit, it can be caused by a few different things. First can be low oxygen levels. So chronically low oxygen levels in your environment, whether you live at high altitudes, or if some people, when they train at sea level, they'll wear a mask that simulates high altitude. So where you have naturally low oxygen, your body will try to counteract that. It'll try to work its way to offset the low oxygen in the environment by increasing the amount of red blood cells to try to increase the total amount of oxygen it can hold. So your body, if we have not enough oxygen available, it'll increase its red blood cells to hold on to more and more and more. Is that what triggers altitude sickness? Altitude sickness is more of, this isn't what triggers altitude sickness. This isn't something that happens on an acute level. Altitude sickness is just, hey, there's a lower partial pressure of oxygen. Your brain's not getting enough oxygen. Your body's not, well, it's getting enough, but ideally not as much as it would otherwise, where it just causes a lot of stress in your body. You feel like trash. Your RBC volume is super small, so I have a high amount of RBCs to compensate for it. Can you reword that? I know what you're saying. Then dehydration. So let's just say you're dehydrated. If you're dehydrated, you have less water in your body, and less water in your body would just mean less water in your plasma. And that would naturally, kind of artificially, give you an acute high hematocrit because the percentage of your blood will be higher in red blood cells just because you're having low water levels. And some people just have genetics that give them a naturally high hematocrit. Um, so, the reasons why if you think about where our Olympic training center is, it's in Colorado. Colorado is at a very high altitude. So what we do is we train where there's low oxygen, and we get these athletes ready to deal in low oxygen, settings. So when they go back down to sea level to compete, they have a now high hematocrit. They have more oxygen available to their muscles, endurance increases, lactic acid production is lower. And so Colorado training up at higher altitudes is kind of an athletic advantage. And so when you have people like Russia who blood dope, what they do is they're giving themselves, without training at high altitude, they're giving themselves a higher hematocrit to essentially replicate that effect. So blood doping and giving yourself a higher hematocrit can get you banned from the Olympic Committee. So don't do that. All righty. So oxygen and hemoglobin. What is this very fascinating protein that does carry the oxygen throughout the body? And so we have 4 subunits, which are just 2 alpha subunits and 2 beta subunits that have a heme group, so have an iron in it. And so what the oxygen does is it binds to this iron. So we have these hemoglobins that flow through the body. It goes from the right atrium to the right ventricle, right out to the pulmonary artery into the lungs. At the lungs, you breathe and you bring in oxygen from your environment. That oxygen will then be bound to the hemoglobin that is now in that blood in your lungs, so that it can travel, it can transport, carry, deliver to all the rest of your tissues. So each hemoglobin protein can bind to 4 oxygen molecules. There's 4 subunits. Each subunit has a heme group. Each heme group can bind an oxygen. So hemoglobin binding does exhibit cooperativity. And so what that means is, let's say we have 2 hemoglobins. I'm going to draw my very fancy hemoglobins right here. 4 subunits. This is hemoglobin 1. This is hemoglobin 2. Let's say, whoop, that is terrible. We have oxygens traveling this direction. Let's say we have 1 oxygen come through. Let's say it binds right here. It binds to this subunit. The next oxygen that comes through is more likely to bind to this hemoglobin than it is to this hemoglobin, because for each additional oxygen that the hemoglobin is bound to, it increases its affinity. It wants to hold on to it more. And so for each additional one, we're more likely to fill up an entire hemoglobin before we start filling up the next one. And when we unload this oxygen from the hemoglobin, it does the same thing in reverse. We are more likely to unload one entire hemoglobin before we start unloading the second one. And so when you look at the affinity curve, or percent saturation versus concentration, that's a brackets concentration, for each additional hemoglobin, for each additional oxygen bound to the hemoglobin, will create an exponential increase in its affinity until we reach an overall saturation where it's completely bound. We have all 4 bound, where it reaches its threshold. So any sort of protein and an affinity curve that exhibits cooperativity, whether it be in hemoglobin and oxygen or something else you learn in biochemistry, any graph that exhibits cooperativity looks like this, looks sigmoidal, where for each, as the concentration of oxygens increase, the affinity, the percent saturation is going to increase exponentially, just because for each additional oxygen is bound to, it's going to be more and more affinity. And then it's going to reach its point where it's saturated, and it's going to drop off like that. Let's see. I'm going to clear this out. There's a couple questions. One oxygen bound to a hemoglobin increases affinity of hemoglobin for O2, correct. And what is one physiological advantage of cooperative binding in this case? It just makes it easier for the hemoglobin to pick up the oxygens overall. So it's going to increase evolutionarily, it's going to increase the ability of your hemoglobins to overall bind to oxygen. So yeah, we can actually try to apply this a little bit more, this is the hardest slide of today, I promise. Okay, oxygen hemoglobin dissociation curve. Let's actually apply what the affinity or changing in affinity actually does. So as we see on a graph here on our right, we have the oxygen partial pressure. Partial pressure of oxygen just means the concentration. So partial pressure in this case is just concentration. And then we have the oxygen saturation of hemoglobin on the y-axis. So as we bind each, additional oxygen, we're going to exponentially increase, and then we're going to bind off. So this is what the sigmoidal curve looks like. This curve, you can tell right off the bat, exhibits cooperativity. So there's a couple of standalone questions where it gives a bunch of different saturation curves, combining. So a lot of them look like this as well. So one that does not exhibit cooperativity will look more like this. If you've taken biochem before. But it just says which of the following graphs exhibits cooperativity. So whatever is sigmoidal exhibits cooperativity. So this was an infinity curve. What it means is at this specific oxygen partial pressure, on average, this percentage of hemoglobins will be saturated. And at this specific partial pressure, this is the percentage of hemoglobins that will be bound. So in any physiological process, we can actually shift this affinity curve. And so shifting this affinity curve is essentially what's going to cause either your hemoglobin to hold on to oxygen or release it to its tissues. So shifting this hemoglobin affinity curve is what's going to tell the body what to do with the bound oxygen. So let's actually do that. Let's draw a second graph here. So let's draw a second graph. That's terrible, but this is a right shift. The graph, our normal resting state line is in red. Our next line is in blue. It is a right shift, a shift to the right. What this is saying is to reach a certain saturation, let's just say right here, for the red line, we need a lower concentration than the blue line to reach the same saturation. So if we need a higher concentration of oxygen to reach the same saturation, we have a lower affinity. It's not going to be holding on to its oxygen as strong. So the conceptual reasons for having a decreased affinity versus increased affinity are where this kind of gets hard. So why would we want a decreased affinity for oxygen? We want a decreased affinity for oxygen if rather than wanting our hemoglobin to hold on to it when we reach the capillary level, we want to kick it off. So a decreased affinity for O2 just means, hey, we're going to deliver the oxygen to the tissues rather than hold on to it, rather than our hemoglobin holding on to it as it passes through the capillaries. So decreased affinity, I'm going to repeat this, decreased affinity for O2 by the hemoglobin means we want to kick it off, get rid of it at the tissue level, deliver it to the tissues. Why would we want to do that? So physiological processes that can cause you to do that. High partial pressure or high PCO2, high partial pressure of CO2. What does that mean? That means we have a lot of CO2, a lot of waste. We're using up oxygen at the tissue level. If we have a high partial pressure of it, we know, hey, we need to kick off the O2, deliver it to the tissues, and pick up PCO2. If we have a high concentration of protons or a low pH, meaning it's acidic. If we're acidic at the tissues, we have a lot of lactic acid building up. We have some metabolic acidosis going on. We needed to deliver O2 because we're undergoing some metabolic process. We need to deliver the oxygen to the tissues. We need to get the tissues to use this oxygen. Increase 2,3 diphosphoglycerate. So this is taking a byproduct of glycolysis. You have the 1,3 biphosphoglycerate. You can use a enzyme to turn it into 2,3 DPG. So what this is going to tell our hemoglobin is, hey, we're undergoing some metabolic process. We're undergoing some energy production. We are working. So it's going to tell the hemoglobin to kick off the O2. And actually, it binds to the 2,3 DPG. The 2,3 DPG is actually going to bind to the hemoglobin, cause some conformational changes to kick off the O2. And same thing for temp. If we have a high temperature, we're undergoing a lot of different metabolic processes. We're using O2. And so that's going to cause the oxygen to leave the hemoglobin as well. So let's have a left shift now. If we have a left shift, what does that tell us about the affinity? So if we draw those lines again, this is how I interpret affinity curves. To reach this certain oxygen saturation, this left shift is going to require a lower concentration of oxygen to reach the same saturation level. That is not a straight line. A left shift means you have a greater affinity. So what a greater affinity means is that rather than kick off the oxygen to the tissues, the hemoglobin is going to hold on to it. We don't need to deliver oxygen to the tissues. Maybe we're at rest. Maybe we're not actually doing anything. So what are the physiological conditions that tell the hemoglobin, hey, don't kick off the O2, increase your affinity, increase how strong you're holding on to it, don't let it go? If we have low partial pressures of CO2, if we're not using a lot of energy, if we're not creating a lot of CO2 byproduct, we're not using up the oxygen. If we have a low concentration of protons, again, we're not creating a lot of lactic acid. We're kind of just resting, being a potato. We're not doing much. Same thing with a low 2,3 DPG. We're not undergoing a lot of glycolysis. And same thing with temperature. We're not undergoing a lot of different metabolic processes. We're not creating energy. We're not using up the O2. So rather than deliver it to the tissues, we're just going to hold on to it. We're going to create this reserve. We're not going to use it. And rather, it's going to increase the hemoglobin's hold onto the O2 and not deliver it to the tissues. And then a left shift or increase in affinity is also what a hemoglobin, fetal hemoglobin, oxygen hemoglobin dissociation curve looks like. And we'll talk about fetal hemoglobin in babies and fetal circulation at the Repro and Dev lecture, but the fetal hemoglobin has a greater affinity for O2 because it needs to rip it off the mother. So let's see. There's a couple questions I've just been ignoring. There's a question, is the math exactly x to the n straight exponentially? Not quite, because it can bind onto a non-filled hemoglobin, but it's less likely to. So it's not a straight, exponential. It just has an overall exponential shape to it. To clarify x versus y axis, the more free oxygen we have in the blood, the more heme will be bound to O2. Yeah, so if we have the higher partial pressure, higher concentration of oxygen we have, it's going to cause a greater oxygen saturation in hemoglobin, just because we're going to supersaturate the hemoglobin because there's so much oxygen available. And then can we make the analogy that we shift right when working out and shift left when resting? Absolutely. That is what causes that shift. So if you're shifting right when you're working out, that's because we need to deliver oxygen to the tissues. And when we shift left, we don't need to deliver oxygen to the tissues because we're not undergoing too many metabolic processes. So partial pressure on the x-axis is akin to O2 concentration. Partial pressure of oxygen is the oxygen concentration. So when you have gases, gases aren't necessarily written as in molar or anything. They are written in partial pressures. So a partial pressure of a gas is a concentration of gas. Alrighty. And just a couple more slides here, just really quick. Nervous versus endocrine control. Whoop, I did not get rid of my drawings. So we did talk about the autonomic nervous system and sympathetic versus parasympathetic. And so they have different neurotransmitters and thus different receptors. So if we can see here, we can control the rate at which our heart rate beats, and we can control the arterioles, whether it's vasodilated or vasoconstricted based on sympathetic versus parasympathetic nervous system signaling. So let's say if you look here, we look at sympathetic nervous system. What we can do is at the heart, it would increase beat frequency and stroke volume. It's going to make the heart beat faster and beat harder. So what's going to happen is it's going to signal to the alpha receptors and the beta 1 receptors. So we see the adrenergic type receptors, alpha, beta, adrenergic receptors. So now I have norepinephrine. So norepinephrine, if we put it on the heart itself, well, it's a sympathetic signal. It's going to increase the beat frequency and stroke volume. Your heart's going to beat faster and harder because you're running for your life. And the arterioles, what the sympathetic nervous system will do is you see, oh, there are little opposites here. We have decreased diameter and increased diameter. How does that make sense? What it will do is it'll decrease the diameter of the vessels, signaling to organs which you don't need if you're running for your life, right? For your stomach, you don't need to digest lunch. If you're running for your life, you need to focus that energy on your muscles so that you can get away and live. So what it's going to do is it's going to decrease the diameter going to the stomach, and it's going to increase the diameter of the arterioles going to your muscles. And that's called shunting. It's going to, the liquids and fluids are always going to follow the least resistant path. So if we decrease the diameter of the arterioles going to the stomach, it's going to cause a bunch of resistance. And if we increase the diameter of arterioles going to the muscles, that'll decrease resistance so that we can shunt blood to the organs that need them most. And for the parasympathetic nervous system, we use the neurotransmitter acetylcholine. Acetylcholine will go to the heart and it'll decrease beat frequency. And so exposing the heart to norepinephrine is going to increase the beat frequency and stroke volume. Exposing it to acetylcholine will decrease beat frequency. So what increases diameter again? So the norepinephrine on certain types of arterioles supplying the organs that need them, like the muscles, norepinephrine will cause the release of different factors to cause that smooth muscle to relax and open up so that you can decrease the diameter, decrease resistance, and shunt blood towards the muscles when you need them. So really, depending on what type of arteriole it's signaling to, it will either decrease or increase diameter to shunt blood to where it needs to go. Alrighty, and where exactly does this really work on? It works on the electrical conductance of the heart, the SA node. So the SA node is where we're going to deliver that acetylcholine or deliver that norepinephrine to change the pace of the heartbeats. So the SA node, the very top here, sinoatrial node, is going to be that pacemaker. It's going to dictate whether our heart is beating really fast or really slow. What's going to happen is we're going to get a signal from the SA node. The SA node is going to send an electrical signal to both atria. It's going to travel throughout the atria, and the atria are going to contract. As that electrical signal passes through the atria, it'll reach the AV node. So the AV node is shown right here. It's going to send an electrical signal down the bundle of His, out through the Purkinje fibers, and then the electrical signal is going to cause both ventricles to contract. So you can have issues where you can have supraventricular tachycardia, where you're getting a bunch of just random electrical signals, and the ventricles and they're contracting really fast. You can have atrial fibrillation, where you have a bunch of random electrical signals in the atria, which causes them to contract randomly, thus essentially not allowing full relaxation of the heart and elevated heart rate. It's not good. But in an ideal heart at rest, the SA node will just send an electrical signal, atria contract. The electrical signal reaches the AV node, which is going to go down the bundle of His out to the Purkinje fibers, which is going to cause that to contract. Personally, I've never encountered too many EKG reading type questions. So you can, I think it's in the book, you can look at how to read an EKG, but that is not something if you're short on time or really behind, that is not something I recommend too much attention on. Alrighty, so we'll come back to the passages at the end. But just to make sure we get some of you guys out on time. Let's go to respiratory. That is not respiratory. Let's see. My computer does not want to share the respiratory screen. There we go. You guys can see respiratory, correct? Awesome. Cool. Okay, so let's go through this so we can get, if you don't want to stay for the questions, get you out on time. What we need to know for the respiratory system. Unfortunately, it doesn't get too much love for the MCAT. So what you need to know is not too much depth. I have not shared these guys before. Sorry. Let me share the respiratory slides. Okay, so I just sent respiratory. And I'm going to send cardiovascular after that. So, alrighty. So let me know if you can't open the respiratory. So doesn't get too much love. What we need to know about the respiratory system, its general function. It works for gas exchange, thermoregulation, and protection against disease. It filters the environment for us. So we're going to talk specifics about thermoregulation, alveolar gas exchange, particulate filtration, how breathing affects the pH of the body, and how it kind of relates to the nervous control, and how the nervous system, it doesn't quite measure oxygen in our bodies. Rather, the nervous system is sensitive to carbon dioxide. So it measures the amount of oxygen in the body by looking at carbon dioxide specifically, and we'll look at why they're even related in the first place. All right, let me get a sip of water. Okay, so the anatomy and structure. So everything shown here is respiratory system, right? We're going to breathe through our mouth and the oral cavity. We're going to breathe through our nose. Once we pass that, we're going to go to the back of the throat, what's called the pharynx. Once we go past the pharynx and through the epiglottis, we'll talk more about the GI lecture. We'll go into the larynx, also called the voice box, through what some people might call the windpipe or the trachea. I had someone a few classes ago think that the difference between a feeding tube, the esophagus, and a breathing tube, the trachea, was a myth and that they were the same tube. No, it is very, very different. You do not want food going down your trachea, because food going down your trachea would get into your lungs and lead to an aspiration pneumonia. You do not want to aspirate your food. Once you go past the trachea, you go into the right and the left lung. And then muscular, we see one muscle here. One of the muscles involved in your breathing mechanisms, which we're talking about in a bit, is the diaphragm. So looking at the difference between the two lungs, the right and the left lung, they are not symmetrical. The right lung has 3 lobes, left lung has 2 lobes. The middle lobe on the right is, for some people, completely useless. I see a lot of patients who have this thing called right middle lobe syndrome. Right middle lobe syndrome is where the right middle lobe collapses and they don't feel a darn thing. They don't feel short of breath, no pain, nothing. It just collapses, and that's something you have to monitor because when it collapses, it can become a breeding ground for bacteria. So some people that have right middle lobe syndromes get this pneumonia, which causes a lot of issues. And so people can go in and just resect or take out the right middle lobe, and they're good to go. And so you don't need every single lobe to work, but the right lung has 3 lobes, the left lung has 2 lobes. And so we can see here as we go through the trachea, we go into the right main bronchus and the left main bronchus, we keep branching out. And so we're branching and branching and branching all these airways. And so when we branch out, we enter the respiratory tree. So the respiratory tree is cartilage reinforced. Otherwise, if it wasn't cartilage reinforced, it would collapse on itself because the breathing mechanisms, when you blow out, are essentially contracting our chest cavity or thoracic cavity to squeeze out the air. And we'll talk about breathing mechanisms and respiration mechanisms here shortly. But if we didn't have cartilage reinforcing our airways, when we breathe out, the lungs would essentially, the airways would collapse on each other. So if you have things like COPD and emphysema, a lot of these airways become very, weak. The cartilage starts to waste away, the walls of the airways become weak, and so when you blow out, you cause these airways to actually collapse and you start trapping air. So a lot of people with COPD have hyperinflated lungs because they've trapped so much air. Their lungs just keep expanding, expanding, and expanding. Gas exchange, when we actually talk about breathing in the oxygen, blowing off the carbon dioxide, doesn't occur until the bronchioles. And so at the big airways, these large airways, we're not getting any gas exchange. A lot of the gas exchange is occurring at the bronchioles and more so in the alveoli. What the alveoli are at the very end of your respiratory tree, at the very end of your airways, are these sacs, these little balls. And so what they're doing is they're having they're having these balls, creating this giant surface area. So alveoli, the purpose is to create a giant surface area to allow for more gas exchange across a surface. And so the capillaries, the pulmonary capillaries from the pulmonic circulation, they cover the alveoli. So where a lot of the money making's happening in the gas exchange is at the alveolar level. And so you can have, with people with emphysema, what happens is they've damaged their airways and they've destroyed their alveoli. Destroying the alveoli, they've essentially destroyed the amount of surface area available. And destroying the amount of surface area available for gas exchange, their oxygen uptake is impaired. The alveoli question, is it the whole sac structure? Yeah, so this whole thing is the alveolar sac. These are all different alveoli. And so alveoli, it's the alveolar sac is all of the balls. What's each one of the balls is an alveolus, and so plural, it's alveoli. Yep. Are these branched off the lung? So if we go back, when we look at this respiratory tree, we're at the very end of these small airways. So if we look at this, all the alveoli are really at the end of these small airways. They're just not shown here. Alveoli are too small to be seen with the naked eye. They're very, very small, but there are so many. And they exist at the very end of these respiratory trees. That is the general structure of the airways. So it's something to keep in mind as well. These airways are not only lined with cartilage, they're also lined with smooth muscle. And so you can constrict and dilate your airways. So you can have bronchoconstriction and bronchodilation. So depending on what you're doing, if you're running for your life, you need more air. And so what's going to happen is the sympathetic nervous system is going to vasodilate. It's going to open up your airways. When you are relaxed, you're going to have more vasoconstriction. You don't need that much air. So it's just going to relax down. You're not going to vasodilate, and your airways will become a little bit more constricted. Now, let's say people have asthma. What asthma is it's inflammation of your airways that causes these smooth muscles to constrict and even twitch. And so when people have asthma and they have this uncontrolled cough, what it is, it's these smooth muscles are twitching, causing a cough. When you have an asthma attack or someone has anaphylaxis, what's happening is these airways are having so much inflammatory factors that the smooth muscle is going to constrict and it's going to close off the airways. So smooth muscle is what causes the airways to open up or close down. So what inhalers do, so if you ever think of albuterol, what albuterol does is it's a short-acting bronchodilator. And so what it does, it's a short-acting beta agonist. It's going to essentially trigger the sympathetic nervous system receptors in these airways to cause them to open up. So people with asthma, there's different things we can do. We can have them take inhaled steroids. Inhaled steroids decrease inflammation, decrease the bronchoconstriction. They could take beta agonists, which trick the sympathetic nervous system to fire and open up the airways. And you can also do muscarinic antagonists, where it shuts off the parasympathetic nervous system that tells it to relax and close down. So there's different things we can do to keep these airways to open up. We do the same thing for asthma and COPD type patients. Smooth muscles in the airways are very important. Okay, breathing mechanisms. How does breathing actually work? So as I mentioned briefly during shunting, fluids always follow area of least resistance or go from high pressure to low pressure. And so what we're doing in breathing is we are changing the pressure inside the thoracic cavity. When we breathe in, we're going to increase the volume of our chest cavity. And when we increase the volume of our chest cavity, we're decreasing the pressure. So the pressure inside our chest cavity is going to be less than that of the atmospheric pressure. And so naturally, what's going to happen is the atmospheric pressure is going to push air into our lungs. And then when we breathe out, we're going to decrease the volume of our chest cavity. What that's going to do is decreasing the volume is going to increase the pressure. And so we're going to have the pressure inside our chest cavity push air to the lower pressure that is atmospheric pressure. So all breathing is it's changing the volume of the chest cavity to change the pressure. Increasing the pressure of the chest cavity blows air out. Decreasing the chest pressure by increasing volume brings air in. So there's two sets of muscles that really does this. First is the diaphragm. So the diaphragm is below the lungs. When it contracts downward. So when you breathe in, take a deep breath, you're contracting your diaphragm. It's going to go downwards. And what that's doing is that's creating greater volume. As it creates a greater volume, it decreases the pressure in the chest cavity and air would rush in. When you breathe out, your diaphragm relaxes and it pushes back up. It's going to increase the pressure in the chest cavity by decreasing the volume. So as you breathe out, your diaphragm relaxes and it's going to push the air out into the atmosphere. The second set of muscles are the intercostals. So these guys are muscles between your rib cage. There's two sets of them, external intercostals and internal intercostals. External intercostals help with inhalation and internal intercostals help with exhalation. So that's something don't get mixed up. Internal do not help with inhalation and external do not help with exhalation. External intercostals help with inhalation and internal intercostals help with exhalation. So what the external intercostals do as they contract if external intercostals help with inhalation, it's going to want to increase the volume of the chest cavity. So the external intercostals, as they contract, they pull your rib cage up and out. Bringing your rib cage up and out increases the volume in your chest cavity. It's going to decrease the pressure and breathing air in. Internal intercostals do the opposite. They contract inward and decrease the volume of the chest cavity. Decreasing the volume of the chest cavity will increase the pressure and blow air out. Internal intercostals are usually just there. They're really just relaxation, and most of it's just caused by the contraction and relaxation of the external intercostals. When you need effort in blowing out, that is when the internal intercostals really get engaged. They don't get engaged unless effort is needed to blow out. All right, any questions on breathing mechanisms so far? We haven't gotten the gas exchange just yet. That's just breathing mechanisms, how we bring air in and blow it out. All right. Thermoregulation. So dogs pant, and what that is that's blowing off hot air. And so we can use breathing for us does help with regulation. Why don't we pant as much, or why don't we pant like dogs do? We have other mechanisms. We can sweat. So something that breathing can do is it helps with regulating our internal temperature. And so when we breathe, we don't just breathe out carbon dioxide. The more correct term is we breathe out wastes. So heat is a waste. We breathe out water vapor. So if you ever breathe on a mirror, right, and it kind of like fogs up, we're breathing out heat, water vapor, and carbon dioxide. So the most complete term, the complete function of the lungs is to bring in oxygen and breathe out waste. That waste is that heat through the form of water vapor and carbon dioxide. So breathing helps with thermoregulation. We can breathe off that heat. Particulate filtration. This is one that hasn't really gotten a ton of love until the past 2 years, but our lungs are really our window to the world. We breathe in so much stuff. We breathe in so many pollutants, right? Pollen, different allergens. We breathe in fungus. We breathe in bacteria. We breathe in viruses. We breathe in just everything, right? And so not good. Only thing that should be going into your lungs is air. Yeah, so not good. How do we actually deal with that? The lungs have developed a mechanism of particulate filtration. It is lined with cilia and it is lined with mucus. And so what happens is when you do breathe in that ash, or if you're in LA and breathing in that pollution or breathing all that fungus, it's going to get attached itself to the mucus in your airways. And what's going to happen is it's going to implant itself in that mucus, and the cilia are going to kick it up. So it has its own mechanism of filtering all the particulate matters. It's going to go in, get stuff stuck, and it's going to go out. So when you do have a respiratory infection, let's say you have, I guess, a bacterial pneumonia. What's happening is you get that bacteria that gets itself, starts propagating and growing inside your lungs. A lot of it's coughing. So a lot of people say like, oh, take cough syrup, suppress the cough. Cough is actually a great thing. Coughing is helping you get rid of all this stuff. It's taking it out of your lungs. So that is something to keep in mind. You don't want all that, gunk just to keep sitting and building up in your lungs. You want to cough it out. And so it is called pulmonary toilet is actually the term for cleaning out your lungs. So a lot of people do have chronic infections, whether it be due to immunocompromise or something. Their recommendation is pulmonary toilet. Cough up as much gunk as you can. Now, sometimes you
the mucus and the cilia don't do their job, and you get things that float past and get into the alveoli. Well, that would be bad, because if we have stuff that just build up and build up and build up in the alveoli, you're pretty much going to suffocate yourself, because you're going to be blocking off all that surface area. So we do have macrophages, other white blood cells on the alveolus surface, that if this ash, let's say, just evades all this mucus and cilia and it gets into your alveoli, we can try to clear that out. So the lungs have a huge immune role. So that is something that I don't think lungs get enough credit for. Give your lungs some credit. All right, so gas exchange. How does gas exchange actually occur? And so the actual law that kind of governs this is Henry's law. It's the difference in partial pressures or concentrations of these gases that causes it to diffuse one way or another. Just like all diffusion, right? We're going to diffuse from high concentration to low concentration. And that's what it is in the alveoli. When we breathe in, the air that we breathe has a partial pressure of oxygen of 149 millimeters of mercury. The air that we breathe in has a partial pressure of CO2 of 0.3. So the air that we breathe in is really a lot more oxygen than carbon dioxide. So when we get to the alveoli, we do have some stale air, some air that maybe didn't get breathed out the last breath. As we get into the alveoli, the concentrations, if I draw of them, or that's pink, that's not a good color for this. Red should be fine for now. The concentrations of the air in the alveoli, we have a lot of oxygen and not a lot of CO2 compared to each other. So as the deoxygenated blood is flowing back to the lungs, right, it's going to go to the lungs, and we have this very low partial pressure of oxygen, a higher partial pressure of carbon dioxide. And so this high partial pressure of carbon dioxide, 46, is going to diffuse to this 40. That's the air in the alveoli. And the partial pressure of oxygen, about 100, is going to diffuse towards the 40. So what that's going to do is, by the time it leaves the alveoli and that diffusion has occurred, arterial blood has a lot more oxygen than it does than carbon dioxide. The partial pressure is 100 and 40 respectively. So as we go back to the tissues have just been using up all the oxygen that's been delivered to them. It's been using the oxygen for different metabolic processes. So what's going to happen is the partial pressure of CO2, which is now 46, is going to diffuse to the 40. And this that was 100 is going to diffuse to this 40. And so what happens, why gas exchange even occurs, it's not some chemical process that is just, converting one to another. It's just raw diffusion. So the differences in the concentrations of arterial blood to the I guess, gas concentrations at the skeletal muscle. So it's going to cause oxygen to diffuse into the muscle and carbon dioxide to diffuse out and go back into the blood. And then when we go back to the alveoli in the lungs, the high partial pressure of oxygen in the alveoli is going to cause the oxygen to diffuse into the blood, and then the carbon dioxide is going to diffuse out. And so that is the basis of Henry's law. That is why gas exchange does occur. It's simply just diffusion of different concentrations. So for gas exchange to occur, you need three things. You need ventilation, diffusion, and perfusion. So ventilation is the mechanical breathing in air, breathing out air. Diffusion is the gas exchange across the alveolus surface and from the capillaries to the tissues. And then perfusion is the blood flow throughout the body. So to get gas exchange to occur throughout the body, you need all three. You need ventilation, diffusion, and perfusion. We're almost done, guys. pH control. So breathing has a large, let me give this annotation, clear. Breathing plays such a large role in the pH of our blood supply. So our nervous system is sensitive to CO2. When you have the blood that gets to the brain, it's not going to say, oh, I have this much oxygen. I'm good. I don't need to speed up or slow down my breathing. What it's going to do is all these chemoreceptors in the central and peripheral nervous system, they are sensitive to CO2. Carbon dioxide concentrations is what dictates in your nervous system whether to speed up or slow down breathing mechanisms. If speeding up breathing or hyperventilation causes alkalosis, or the blood becomes more basic, hypoventilation causes acidosis, too much acid buildup. The reason why is because it's the blood buffer system we're talking into here shortly. But what's going to happen is we have a certain given blood pH, and that blood pH is dictated by the partial pressures or the concentrations of the CO2 and the O2. The concentration of O2 will dictate the concentration of CO2, and CO2 will be picked up by the chemoreceptors. The chemoreceptors will relay information to the brainstem respiratory centers. If you think back to the medulla, right? So the medulla is going to send signals to the breathing muscles, the diaphragms, the intercostals, to either slow down or speed up breathing. Slowing down or speeding up breathing on the muscular level changes the alveolar ventilation rate. And the alveolar ventilation rate will change the blood pH by changing the partial pressure of these gases. So kind of a graphic of what this does at any given moment. So let's say you're sitting here right now, right? Just at rest, you're shallow breathing. You're not breathing too hard. You're not running. For the average person, the alveolar ventilation is about 4.2 liters per minute. You don't need to know the absolute number. That's just to kind of orient ourselves. You don't need to know that everybody breathes at a rate on average of 4.2 liters per minute. If we speed up our breathing, if we speed up the ventilation rate towards 10, right, that's called hyperventilation. In hyperventilation, what happens is your partial pressure of oxygen increases and your partial pressure of CO2 decreases. And the reason why this is happening is you're breathing so fast, you're just blowing off way too much carbon dioxide. So blowing off carbon dioxide is just going to increase the relative concentration of oxygen. So when you start hyperventilating, you start feeling a little bit lightheaded. What's going to happen is basically you're going to pass out. And when you pass out, you're going to go flat and your brain is going to take over. Your brain's telling you, hey, obviously you don't know how to breathe correctly, so I'm just going to take over. So when you feel lightheaded from hyperventilation, the trigger is that the chemoreceptors are sensing way too low of a concentration of carbon dioxide. So it's going to make you pass out so that it can take over. If we start breathing too slowly, what's going to happen is you're going to start retaining CO2. So retaining CO2 is going to make the blood acidic. We'll talk about that next slide. So it's going to lower the pH. And so you're going to go into this acidosis, which is not good. And if you're breathing too slow, you're also not getting enough ventilation. So you're not bringing enough of oxygen either. So you can go into dangerous hypoxia, where your vital organs aren't getting enough oxygen because you're not breathing quick enough. So the oxygen content of your blood isn't high enough to actually meet the demands of your vital organs. And so, I mean, a lot of people experience hyperventilation when they have anxiety or even when you're, working out and you have to breathe faster. Why do you have to breathe faster? Because you're producing so much carbon dioxide that you need to blow it off. So hyperventilation is going to blow off that carbon dioxide. But not too many people experience hypoventilation. An example of a disease with hypoventilation is called Pickwickian's syndrome. Pickwickian syndrome is also called obesity hypoventilation syndrome. So let's say someone is so big, so heavy, that the fat in their stomach and the fat on their chest are really preventing their chest cavity from opening up when they're taking in breaths. They're having very, very shallow breathing. The amount their chest opens up is not what it should be. And so because we're not getting a high enough volume in a given time, you're going to essentially start coming this way towards hypoventilation. And a chronic hypoventilation, they start becoming CO2 retainers. They start holding on to CO2. Their partial pressure of O2 drops. And so one of the things that obesity causes that a lot of people don't really quite understand, or it's not very popular in society, is hypoventilation, something associated to not diabetes, to obesity. So it's called obesity hypoventilation syndrome. So there are people who chronically hypoventilate and they start retaining way too much CO2. Their blood pH goes down, starts becoming acidic, damages their body, damages their tissues. So why exactly does pH change with the breathing? And that's because of the blood buffer system. So when you do start generating CO2, plus only 7% of it remains dissolved in plasma. Most of that is either bound to hemoglobin, because CO2 can bind to hemoglobin, or it's converted into bicarb. And you can get rid of bicarb by peeing out. We'll talk more about peeing out or not peeing out bicarb. But the altering the concentration of carbon dioxide, if you've heard of Le Chatelier's principle, will take this blood buffer and increase it going one direction or another. So if we have too much carbon dioxide, we're adding more reactants. And so Le Chatelier's principle is going to shove this equation to the right. So you start producing too much carbonic acid. You can start producing a lot of free protons. So more carbon dioxide or carbon dioxide retention is going to cause the reactant side to build up, and you're going to start creating more carbonic acid. Now, if you start having low carbon dioxide, start hyperventilating, blowing too much off, you're taking out this reactant. So you're going to shove this equation to the left. I think in one of the chemical kinetics lectures, you will talk about Le Chatelier's principle in a bit more depth, but essentially the blood buffer system and the concentration of carbon dioxide is going to utilize Le Chatelier's principle. So we have, if you're blowing off too much carbon dioxide, we start taking away the carbonic acid, we start taking away bicarb and whatnot. So that is why the concentrations do matter, is because it plays the blood buffer system. And so your body doesn't just, your breathing rate isn't necessarily always the primary process. So what I mean by that, let's say we have primary process versus secondary process. Secondary process is also called compensation. This is not exactly stuff you need to know prior to going into the MCAT. This is just kind of taking this topic and taking it a little bit one step further. So let's say we have the pH of our body. Let's say we have a low pH. A low pH in our body is causing acidemia, or acid buildup in the blood. So also called acidosis. That could be caused by different things. It can either be due to high carbon dioxide content or low bicarb. If we have low bicarb, we go back to the blood buffer system. Low bicarb means that we're going to be shifting everything, towards the carbonic acid. And also, if we have low bicarb, whether we're peeing it out or something, we're gonna have a bunch of free protons. And a lot of free protons is not something we like. Free protons increases the acidity. So if we have a high partial pressure of CO2, that's because we have there's an issue with our breathing. We are breathing too slow. If the acidosis is caused by a breathing issue, it's called respiratory acidosis. If the low CO2, if the acidemia or acidosis is caused by bicarb, it's a metabolic acidosis. And so your body can react to the primary process being the respiratory acidosis versus metabolic acidosis. So if we have a respiratory acidosis, meaning that we are retaining too much CO2 because we're hypoventilating, our body can go create metabolic processes to create more base. So we can have compensation for respiratory acidosis by upregulating any metabolic acidosis. We can counteract respiratory acidosis by upregulating metabolic alkalosis. If we have metabolic acidosis, we can breathe faster, blow off more carbon dioxide to create a respiratory alkalosis. So an example of a metabolic acidosis, right? You're working out a lot, you're creating a lot of lactic acid, going to a metabolic acidosis, you'll breathe faster to blow off that carbon dioxide. You're going to, with your breathing, generate a more basic change to try to keep your blood pH from a range of 7.2 to about 7.6 pH. The same goes for alkalemia or alkalosis, which is just the base changes. So you can have respiratory alkalosis where you are breathing way too fast, or you can have metabolic alkalosis where, hey, maybe you're retaining way too much bicarb in your urine and you're causing a basic change. If you're causing a basic change in your blood from some metabolic reasons, you can start hypoventilating to create respiratory acidosis. So these are just different things that the body can do. So if you're breathing too fast, it can counteract that with a metabolic process. If you have some metabolic process changing the pH of your blood, your lungs can compensate for that as well. So if you guys don't want to stay for passages, you got to head out. You guys are free to go. We're going to go back to the cardiovascular and go through those passages before we go to these ones. So you guys are free to go and have a great rest of your weekend. If you guys are done for the day and I don't have free time, it is exactly 11. But if you guys do have free time and do want to stay, we'll go over the passages right now. Sorry, it is not wanting to share the cardiovascular lecture. Give me a second here. Let me try to adjust this. There is a question. Do you need to know the cardiac potentials, lung capacities, total volume, reserve volumes, residual and reserve volumes are the same thing, unless you're talking about ERV. But in terms of spirometry numbers, in terms of lung capacity, you don't need to know the lung capacity. Average is about 600 milliliters. I'm trying to adjust, get the cardiovascular lecture up. And in terms of cardiac potentials, no, I've never encountered that on any practice test, any real exam. That's something that the TBR books go into a little bit more detail on. And in terms of spirometries, you'll never have to calculate a spirometry in terms of TLC or total lung capacity and residual volume or expiratory reserve volume. So you guys don't need to know that, thank gosh. Alrighty, so let's go through these passages rather quickly. They're not too terribly hard. Alrighty, I'll give you guys a minute or two to read this and answer the question. When you guys do have an answer to the question, just send it in the chat. If you don't feel comfortable letting everybody know, feel free to direct a message. Alrighty. Looking good. So which of the following are most important explaining how the body changes resistance of arterioles to blood flow? So I think we got this one. It is smooth muscles, right? So it's their contraction or relaxation that causes the vasodilation or vasoconstriction, which that radius is what is the most important for resistance. Endothelial cells, they can release factors that cause vasoconstriction and vasodilation, but they need the muscles themselves to actually do it. If you think and see, it can't be skeletal muscle fibers, right? Because we are in the cardiovascular system. We are not on the skeleton. These are not skeletal muscles. And then arterial valves. We don't have arterial valves. We have venous valves. Arterial valves sounds fascinating, but those don't exist. We have the venous ones. All right, next question. Which of the following mechanisms by which blood flow to the kidneys might decrease during exercise? I'll just wait for a couple more people to answer. Alrighty, so which of the following mechanism by which blood flow to the kidneys might decrease during exercise? So this was briefly mentioned in a couple separate areas. It's kind of tying them all together. Blood vessels in the kidneys constrict and blood vessels in the skeletal muscles dilate. So this is that shunting. So this was, hey, when exercise, sympathetic nervous system will be firing, we're going to send the blood to where it needs to be. And so it's going to constrict some muscles, dilate others. And when we constrict muscles, it's going to increase that resistance. And then that fluid or that blood is going to follow the path of least resistance. And so this is shunting. So when we exercise, we shunt blood to where it needs to go, where it is most needed. And last question, which of the following does not contribute to the lowering in the oxygen saturation in the femoral vein compared to femoral artery? Okay, so think about this one closely. This one usually trips people up. Give it a shot. Alrighty, this is the tougher one. It's a little bit more abstract. So which of the following does not contribute to the lowering of oxygen saturation in the femoral vein compared to the femoral artery? So this is asking which of the following pretty much just doesn't contribute to oxygen kicking off, sorry, to the hemoglobin kicking off its oxygen to the tissues. So increased carbon dioxide production. Carbon dioxide is creating a higher concentration of carbon dioxide. It's using up the O2, so the O2 is going to diffuse from that hemoglobin into the tissues. And so the artery, comparing it to the artery to the vein, it's going to lose its saturation. It's going to lose how much oxygen is bound to that hemoglobin because it's trying to compensate for that increased carbon dioxide. Decrease in pH, meaning it's more acidic. Higher carbon dioxide means decrease in pH. So B and C are essentially the same thing. An increase in temperature, if we look back also at the hemoglobin oxygen dissociation curve, increase in temperature is also going to kick off oxygen. So our saturation will be lower in the vein compared to the femoral artery. So the answer is A. So why is it A? Because from femoral artery to the vein, there is no decrease in hemoglobin levels. Hemoglobin levels are always the same. As long as your red blood cell count remains the same, hemoglobin count remain the same. What differs between artery and vein is whether that hemoglobin is bound to the oxygen or not. So hemoglobin doesn't disappear as you go to the capillaries. It's just the saturation drops because it's kicking off that O2. So hemoglobin levels going from the femoral artery to the femoral vein will be the same. It's whether or not the saturation will be the same. And so it's D because there will be no change in hemoglobin levels between the femoral vein and the femoral artery. So that's not going to contribute to anything. And then the reasoning for D, so increase in temperature. If we go back over here, an increase in temperature is going to decrease the affinity for O2. And so rather than hold on to the O2, the hemoglobin is going to kick it off. So if it kicks off the O2, its saturation is going to drop. Right? So what's going to be adding to essentially which of the following is contributing to the hemoglobin kicking off the oxygen as it travels from femoral artery to femoral vein. B, C, and D are all on this side. They all will make the hemoglobin want to kick it off. Hemoglobin levels from artery to vein do not change. It's their saturation that changes. Okay, let's go over to the pulmonary. When we say, there's a question, when we say kicking off, is this also assumed to be dumping the O2 at the skeletal muscle? Yeah, that's what essentially we're kicking off the O2 from the hemoglobin and delivering it to, it doesn't have to be skeletal muscle. It can be any tissue. But in that slide from the pulmonary, the example was skeletal muscle. So yes, skeletal muscle is one of those tissues that it can deliver to. Okay, there's a question. Can you go back to table 1? This one right here, this table 1 that's shown here, is the femoral vein O2 levels changing because of what you just described versus RE levels staying the same? So yeah, what's happening is we have the percent saturations and the femoral artery is always the same, right? But what's happening is just dropping. So the reason why is because as it goes from artery to the vein, it's going to travel past the capillaries. And when it travels past the capillaries, it's going to kick off the O2. It's going to dump the O2, to this case, skeletal muscle, to any sort of tissue that needs it. Now, the reason why we have 81 versus 68 versus 65 is because we're using up oxygen. We are increasing carbon dioxide production. That's going to decrease pH. And because you're exercising, your core body temperature is going to increase. So all these different things are going to tell the hemoglobin to decrease its affinity, and rather than hold on to it, it's going to kick off. And so when we're at rest, we don't need to kick off as much O2. So that's why when lying down, it's 81 and not 68 and not 65. Does that make sense? All right. Cool. Any last questions before we transition over to the respiratory ones? Okay. Do endothelial cells regulate smooth muscle cells? Yeah, they are one of the things that can regulate smooth muscle cells. So you can either have just direct nervous stimulation, or you can have endothelial cells that signal. So yeah. Okay. Let me stop share. Let me bring up respiratory, if I could find it. Alrighty. So let's see if my computer decides to share respiratory now. Cool. Let's do it. So give a couple minutes, maybe a minute to answer this one. You just might see a pattern here. All right, so this question is, which muscles involved in the prevention of lung collapse? Essentially, which of the following muscles can aid in the breathing mechanisms? And so you have to think. So abdominal muscle, that's not doing anything to your lungs. Deltoid, that is shoulder. Pectoralis major, that is your chest, but it's not important in increasing or decreasing the thoracic cavity. What it's important is it's bringing your arm in towards your sternum. It's attached at your sternum and inserts on your humerus. But the intercostals, they work on increasing and decreasing your thoracic cavity. And so that will help your lungs from collapsing on itself. It's going to keep the thoracic cavity at a nice happy medium. Which of the following is most accurate and complete regarding the function of the lungs? All right, don't get caught in the trap. Most complete, get rid of waste, right? We're gonna blow off water vapor. We're gonna blow off heat, and most importantly, blow off carbon dioxide. So yes, it does bring in oxygen, get rid of carbon dioxide, but that is not most accurate and complete. get rid of wastes as well. That waste doesn't have to be the typical thing you think of waste. Water vapor and heat are considered wastes. 2 more questions. Which of the following best describes the pressure inside the alveoli relative to the outside air when taking a deep breath? All right, the way we actually breathe is by changing the pressure inside the thoracic cavity compared to the outside air. And so when we breathe in, deep breath in, we need to decrease the pressure in our lungs. And so when breathing in, we would need a lesser pressure. And when breathing out, we increase the pressure in our lungs to force the air out. So it is C, lesser pressure when breathing in, greater when breathing out. And then last question, why might this experimenter have decided to take males of a certain weight? All right, I think you guys got this. So it is A, to limit the confounding variable. Remember, if you have people of a certain weight can lead to hypoventilation. It's measuring volume of respiration. And right, if you have a different weight, that can lead to different volumes you breathe in, different volumes you breathe out. And that is a confounding variable. That is something that might get in the way of your results. Compare individuals with different oxygen requirements. That really comes down to how healthy you are. What's the status of your lung parenchyma? Do you have emphysema? Do you have fibrosis? So that's not something that they looked at in this case. That's the weight has nothing to do with that. To prevent attrition, that's over time, fewer and fewer people give results. So that is something to keep in mind in statistics throughout biology. And then B, to focus the experiment on alveolar number. And so that's not necessarily something with weight, that's something with height as well. So as you notice, none of these bio passages, none of these questions really had anything to do with the passage. They did last week for neuro, not so much this week. Something that I have found in the test taking skill, a lot of people that take the MCAT have a bio background. And so what they need to do is they need to find a way to separate the people who have that strong bio background and give people who don't have a strong bio background a super, give them a chance. And so one of the things that I feel like a lot of bio passages have done is they just plaster you with jargon. They plaster you with experimental data, with different proteins, different genes, different diseases. So sometimes if you're kind of getting worked up by that, because that just adds into confusion, makes you second guess yourself, stresses you out, you can't think clearly. My mechanism for bio passages is I actually don't read the passage at all unless I need to. So if we have like 6 questions for a passage, I'll go to all the questions, answer all the ones I can first using the information I needed to know going into the exam, building up on the information maybe the question gives me and answering. And only if I absolutely need the passage will I go hunt and peck. And so if you find yourself getting bogged down in the jargon, that is definitely a technique I recommend just trying and seeing how that works out. I felt like that really worked out for me. It saved me time on bio passages and actually started increasing my score because I was a little bit more focused on what the question was asking me rather than what the passage was trying to confuse me with. So with that, that is it for today. Next week is adrenals, GI, and kidney, which is actually quite an interesting one. I know a lot of people don't like GI stuff, but hopefully I could change your mind. Yeah, so I'm gonna go back. See you guys next week. Have a great rest of your weekend. I will go back to that slide for you. So here's a question on the neuro part of the circulation. Let me pull that slide back up. Alrighty, let's see. So what to kind of pull away from that slide? Let's go. This is the PDF. Gosh darn it. Okay, so if you kind of actually go back through the nervous lecture, I mentioned a couple things. So nervous system lecture, the sympathetic nervous system uses norepinephrine. The parasympathetic nervous system uses acetylcholine. So based on what you actually produce, what you expose the heart to, that itself can give you a sense of what it's going to do. So if you expose the heart to norepinephrine, you can think, oh, well, that's the sympathetic nervous system neurotransmitter. So that'll probably do sympathetic nervous system effects. It's going to increase beat frequency and stroke volume. And if you expose the heart to acetylcholine, which is the parasympathetic neurotransmitter, it would do parasympathetic effects. It would slow it down. And so based on just knowing that what the parasympathetic and sympathetic nervous system neurotransmitters are respectively, you can get a sense for what it's going to do. And when you get to the type of receptors can also give you a sense as well, because you have parasympathetic receptors and you have, parasympathetic receptors here and sympathetic here. So the sympathetic nervous system receptors also, if you go back down to the nervous system lecture, you have adrenergic receptors. So the different types of adrenergic receptors are alpha and beta. So yeah, alpha, beta 1, beta 2. What type of alpha, what type of beta, it doesn't matter. Just if you see alpha receptor, think adrenergic. So that will be more of a sympathetic response. If you have an agonist to an adrenergic receptor, that's going to mimic a sympathetic response. If you have an agonist to a sympathetic receptor, that'll cause a negative response, the opposite of sympathetic. So we'll talk more about agonists versus antagonists in a later lecture. That's in the endocrine lecture because that's a lot of hormonal signaling. But let's say we have a muscarinic agonist, something that activates muscarinic receptors. Well, that will mimic a parasympathetic response. If we have a muscarinic antagonist, it'll do the opposite of a parasympathetic response. So just basically what I was trying to get on this slide is, depending on if we, at the heart level, right, if we expose it to norepinephrine, or let's say we activate a beta receptor, you should be able to predict what that will do. Sympathetic, because those are sympathetic responses. If we activate that, it'll increase beat frequency and stroke volume. It means your heart beat faster and stronger. If we activate it with exposing it to acetylcholine or activate muscarinic receptors, you should know what that should do to the heart, because the parasympathetic response, it will slow it down. It will decrease the beat frequency. So does that make sense I was trying to get out of that slide. I just had to speed up because we've taken so long with the tangents. So awesome. I am glad. You two have a good weekend and week.